Welcome everyone to the first session of 2022. We have two speakers for today's session rather than our conventional three. We're going to have two speakers for all sessions for this year. So our first speaker will be Dr. Rosemary Higgins, who is our guest speaker, who'll be presenting a talk titled Motivational Interviewing and Goal Setting, Lessons Learned from My Practice. And our service of the month is the Whyalla Clinic Rehabilitation Service, and Linda Marshall will be presenting. So today's session is related to Module 1 of the Catch Web program. So patients in Catch Web and indeed in all modes of cardiac rehab are guided to think about their personal goals for rehab. And the goal settings questions come up during the first module, and it links it to the baseline assessment tools. So web patients may be completing their program with minimal interaction with their cardiac rehab nurse. So helping patients to set realistic and achievable goals during that initial contact that you have with them is valuable for their long-term success, which is how we've ended up with Rosemary as our speaker today. So just a little housekeeping before introducing Rosemary. We're keen to provide some sort of accreditation for our 22 series. So we're tracking attendance really closely, and we hope to offer some recognition to the members who come along to the sessions to hear the content each month. We've also introduced a new approach for evaluating the sessions this year. So at the end of each session, Zoom will take you to a page with 3 multiple choice questions about the session. It'll be the same questions each month, so very predictable, and it's all anonymous. So this will just let us know if the speakers that we've got are hitting the mark with members. So to introduce our first speaker, Dr. Rosemary Higgins is a clinical health psychologist and an active researcher working with the Australian Centre for Heart Health, previously known as the Heart Research Centre, and they're developing innovative innovations for supporting patients to cope with and manage the psychological and social impact of chronic health conditions and other life changes. Rosemary lectures at the University of Melbourne, Swinburne University, and until recently was an honorary associate professor at Deakin University.
I still am, haven't been sacked from that one.
I went to your page on Deakin University and it's down. You should let them know.
I'll let them know.
Excellent. So, and is currently an honorary associate professor at Deakin University. So Rosemary integrates cognitive behavioural therapy, acceptance and commitment therapy, and family therapy into her treatments and research. And her current cardiac health projects include Understanding the Cardiac Blues, a Beyond Blue funded project, and extending support for chronic disease and self-management in the Victorian cardiac rehabilitation programs. And I do think this deserves a mention because I found it. Rosemary Higgins last year received the Allen Globe Distinguished Service Award for extraordinary service to cardiac rehab. So we are very lucky to have her here today. So now I will hand over to Rosemary and she can share her intellectual wisdom with us. Thank you, Rosemary.
Hopefully there's practical wisdom as well as intellectual wisdom, because people can get a bit bored with too much intellectual wisdom. So I'm just going to share this. Can you see that?
Yep.
Yep, great. And everyone can hear me okay?
I can hear you just fine. Do let us know if anything crops up, audience, if there's any time you can't hear.
Okay, I took your briefing lessons learned from my practice very seriously, because I think it's that sort of practical application of what you've learned over the years and how I can condense that into a 20-minute presentation. So I'll just... So the first one is measure what you manage. So if you're going to work in behaviour change, we want you measuring. So you measure everything else. People are great at measuring. But you think about how often you measure importance and confidence when you're talking. Some of you will do it all the time. Some of you will do it sometimes. And some of you have never thought about doing it. It's sort of like watering a garden. If someone's confidence a 10 out of 10, it's like watering the garden when it's soggy. It's not going to help. It's not going to help anything to grow. Or if someone's low in confidence, and you don't water that, you just talk about importance, again, you're missing the mark. And what's most important, because time is valuable, is you're wasting your time and you're wasting the client's time. You're working on stuff that doesn't need to be done. So you're wasting resources, their energy, you're wasting their connection, and you're wasting your time, and you're going to get frustrated. So this is the first one. And I think it's very simple. It's if you're setting a goal, even a vague goal, how important is this to me? So think about your own lifestyle changes or your own health-related behaviours, your own things that you want to change. Your first thing is it's got to be important, or else you're not going to change it. If it's not important, then you're probably unlikely to make a change. But the other thing is that it has to be, you have to have a level of confidence that you can do it. So think of anything that you're trying to do. It might be cutting out sugar in tea, or, reducing binge drinking, or having an alcohol-free day, or having lunch at work, stopping for lunch, or going for a walk in the morning, or, weeding your garden, whatever it is. Think about how important it is to you, and then think about how confident you are. So this is the two things I want you to measure with everyone that you're working in any health behaviour. And then I want you to be very careful that you don't judge them by their measurement, and that you think of this as, how do I intervene? It's not, I'm immediately going to make this more important by flooding you with so much information on tobacco that you're just going to get overwhelmed and never come back. So it's thinking smart. This is where I have to work. I have to work at importance, or I have to work on confidence. And in terms of cardiac rehab, what I notice is many rehab sessions focus entirely on importance. We're doing a major importance intervention, and we might be doing it with people whose importance are 10 out of 10. So it's sort of like watering the garden when it's soggy. Not going to help. So that's our first thing to think of. Another thing is work with where people are at. If you think of yourself in terms of using behaviour change principles in terms of your practice with patients after a cardiac event. You could be where I am, which is intrinsic. I love doing this, it feels great. But you might be just down at introjected. I've internalized the nagging and I better do this. Or you might be at external. Someone told me to do this. So what we're doing, same with our patients, same with ourselves, is we're moving up the scale from controlled to more autonomous, making this part of who we are. So just think about where you are and think about how you can move. And when you're doing this, you can also think about a patient that you see or a client that you see and where they are, and they might be at introjected and you might want to move them to identified. But you're not going to move them instantly all the way to intrinsic, and that's okay. We've got to work with people where they're at. Maybe, you're moving them from amotivated to external motivation. Just being aware that, they're quite vulnerable at that state to move down as soon as there's no one there to tell them what to do. So we want to work more with the values and with tying the goals to values, because that will help them move into identified, which is more where the autonomous. Because in terms of the controlled, as soon as you move the control, flips back down. Okay, other lessons learned from practice is take a broad perspective. See a person as part of the whole social determinants of health. What's your judgment? understand socio-economic, cultural, environmental conditions. Not everything is under a person's control. We know that people who live within a block of a park are more likely to spend time in a park. It's not rocket science. If you've got higher walkability, you're more likely to walk. And we know that in impoverished suburbs, there is less walkability. So it's not, some people are pushing it uphill. So really knowing that it's not all about them and it's not all about you, that there's broader influences. It doesn't mean you're giving up, but you're keeping this in mind and you're taking the broad perspective. And another really, really important is to have a bigger understanding and remain non-judgmental. If you sort of see behavioural patterns as part of coping skills, trauma, emotions, personalities, learning, and you also see all the socio-political stuff and the immune system and the social context, that sort of, you can become much less judgmental in terms of health-related behaviours or negative health behaviours. So we're there to support people to better manage their behaviour, to health behaviours, to try to feel like they're in more control, but we're not there to judge. So their story, and you'll only know little bits of a person's story. You probably won't have the full picture. So seeking understanding is important, and you won't get understanding if you're judgmental. I've met many people who, they'll talk afterwards, oh, he stunk of fags, I can't believe it. It's people can feel your stigma. People can feel your judgment. They feel it in their nervous system. So just be really careful and aware of how and what, pushes your buttons. Because as soon as your button's pushed, you're less likely to be effective. And you're probably going to do harm. So we want to really watch your buttons and your triggers and your judgment. And in order for you to better manage, to remain non-judgmental, increase curiosity. That's you don't know, and know that you don't know, and don't be sure that you do. So in order to support people with behaviour change, we need to understand behaviour, but we need to understand the person. We don't have to be their psychologist, but being curious will assist you in helping them with their goals. Does that make sense? Yeah. And seeing change as a process, not an outcome. Seeing success as not coming from your efforts, it comes from where the person's at. If you don't take credit, if you give the credit to the person, then you won't give then you're sort of differentiating between yourself and them. If their success isn't your success, it makes you easier to manage what you might see as their failure. So we have to not personalize. We have to be able to see that even if we're moving someone from not thinking about something to thinking about it, that's really moved them along the process of behaviour change. And many people who change their behaviour will have had 100 interventions, some of them harmful, some of them helpful. And by the time they get to you, that might be when they're moving into action or maintenance. Sometimes with our cardiac patients, we can see that they've moved from a pre-contemplation state to action overnight. That's quite frequent. Our problem with that is when it's too quick, they haven't backfilled, they haven't created the structure for it. So just work with them and think about what might you need to think about to make this long term? What sort of supports might you need to put in place? So it's really noticing what they've done, but thinking about how you can backfill to create a structure and a support system to build long-term success. You know, what might be your vulnerabilities? What's the sort of things you can say to yourself to help you? Is there anybody out there who's on your side and gets you? You know, if you have a little lapse, what might be your plan? All sorts of ways we can backfill for people who've changed overnight. People find theory incredibly boring. And I'm not going to bore you with theory, but I'm going to introduce you to theory and get you thinking a little bit about how you can use it to structure connection and to structure curiosity. And we know the evidence tells us that theory-based interventions are much more effective. So we know they're more effective, so we have to sort of use it to guide ourselves. And they, you know, if you went to one of those libraries that they have where they have books and journals, you know, an old-fashioned thing that used to happen before the internet, you'll find all the theory. It's in about the 600 to 699 in the Dewey Decimal System. It's filled. There's shelves and shelves and shelves. You can, you know, take a big tour around theory. I don't want you to have to do that. You don't have to know 600 on, but I can introduce you to a little bit that you might already know and you might not. So one is this beautiful combi model. This is helpful because it can help us guide our questions around behaviour change. It helps us know what are the things that predict behaviour change. And so it guides us in terms of our intervention of where we work with an individual or a group around behaviour change. So the COM stands for capability, opportunity, motivation. And you can see the arrows between behaviour and backwards and forwards, that it's not one way, that what people do influences their motivation, their capability and their opportunity influence motivation, motivation influences behaviour, and it goes backwards and forwards. So it's not fixed in space. Motivation can change, behaviour can change, people can build capacity. In terms of capability, we think of the psychological and the physical capability. In terms of motivation, it's not all about that I've made that decision and I'm going to do that. It's sort of getting into the more automaticity. It's getting into the mechanisms that activate the behaviour. It might be the shoes by the door. It might be, you know, when I see the oval, I think of walking. It might be the feel-good thought that we have when we do something that we're proud of. So it might be those emotional feelings of pride or success. It might be, you know, that feeling of achieving a goal. So it's deeper than the thought processes. So we want to appeal to the deeper parts of the brain. We want to appeal to the emotional part, to the parallel processes, side by side. So the reflective, that's your thinking, I'm going to do this today. But there's the automatic, which is another part of your brain. It's really interesting work around this thinking fast and thinking slow. And we're thinking about reprogramming our brain, and that's what we're thinking about to have success. And then we got opportunity, which is both the physical and the social environment. So when we know that these three things impacted the behaviour, we can be curious about all of these. We can have an interview or an exploration that covers all of these. and we can help us know where we can aim our intervention. Another one, say find a model, make a commitment. Don't have to know all these models. There's lots of different ones. Lots of them are really, really similar. So it doesn't help. They're made by researchers to try and get the most prediction of behaviour change. Health belief model, that's pretty handy. How serious is it? Am I likely to get it? Well, people with a cardiac disease, they know it's serious and they know that they're likely to get it. So the importance has already increased. What you are working on is treatment efficacy and self-efficacy and cues to action. And the things you can do in that is increase confidence. Confidence that the response efficacy or the treatment efficacy, this is going to help, and improving self-efficacy and what might help you to get you going. So I quite like the health belief model. It sort of makes good sense and it's easy. If you went online, you'd hit, 6 million things around the health belief model. Self-efficacy, it's a major predictor of behaviour change and very amenable to intervention. So we want to go there. We want to manage emotions and mood because we know that's a major thing that gets in the way. We run a cardiac psychology clinic that people can refer to at the Australian Centre for Heart Health. Just look on our website. That's important. I'm aware of time, so I don't want to go over time. I want us to, in a behaviour change consultation, to be curious and to raise issues without losing rapport. Rapport is most important. We don't want to lose rapport. Anything that we do, we have to keep connection. And what can help us to lose connection very quickly is when we tell people what to do and we're persuading and convincing. We're not the policeman or the police person. We're there to support them with their challenge of behaviour change. If we want to give information, we've got to ask what they want to know, what we want to tell them. Then we help them make sense of it. That's how we move towards goal setting. And we tie it with values and meaning. So important. And we keep connection. People can be quite perplexed and lost. So we don't want to lose connection. And we want to listen to the bits where they're talking about maybe it's possible, maybe I could do this. It could happen, if only. And when we hear that, we want to amplify it. I hear you saying you'd love to be able to do it. I can hear you saying how hard it is, but how much you'd love to do it, because then we're amplifying and we're nurturing. Just because we've got an intention doesn't mean it's going to bloom. We've got to plant it, we've got to water it. Intentions only predict about 33% of behaviour. So just because you've got to intention doesn't mean you've got to behaviour. If you're thinking about goal setting, I want you to think about changing the goal, not the person. If your goal was to walk 15 minutes twice a day and your confidence is 5, we're not going to instantly push the confidence. Oh, you can do it. You can fit it into this time. This is when you should do it. You could reward yourself. No, we're changing the goal, not changing the person. Make the goal possibly could be walk 20 minutes once a day. Importance is still high. Their confidence tells you it's enough to give it a go. That's the goal. Small goals lead to a cascade of change. This is why we measure. This is why we measure this, because otherwise we're just building them up to fail. And that is unhelpful. And in order to build success, we need to do coping planning. And I'll put a little example of a coping planning, which is using resources and support to help So that's, and addressing barriers. So this is what we call facilitators and barriers. I haven't got an example of a barrier one, but it is what might get in the way and what will help you to get over that. So we need coping plans as well as action plans. Nobody talks about coping plans. That's because they only sort of came into the literature in about 2004, and we're all usually about 20 or 30 years behind. So coping plans, they're where it's at. If we want to move on, and it's not all about you. It's about the patient, it's about their story, it's about their change, and it's about supporting them. So I'll leave it there. And this is the various things that we want to get to. Okay, I'll leave it there so we've got time for questions, if that's all right. Shall I stop sharing?
Yep, I think, yep, stop sharing, although that is a fascinating slide. And I will just ask Rosemary, are we able to get a copy of these slides to send to our group?
Yes, I think so. I'll give you a PDF of them.
Fantastic. That would be great. All right. So if you want to stop sharing, we'll open up for questions to the group. I know I have one, but I will wait and give people a chance. So did anyone have a question for Rosemary?
And if you can just introduce yourself when you ask the question.
Oh, yeah. So Jess.
Can you hear me?
Yep.
Loud and clear.
Hi. Thanks so much, Rosemary. That was excellent. I was quite excited about your talk today. It's yeah, I was looking forward to it, so that's great. I have a question about content, standardized tools, and how we balance that with the behaviour change and keeping rapport whilst also getting what we need in terms of measurable outcomes.
Yeah, and I suppose that's about taking the patient with you on the process. So I'm going to be asking you, 10 or 15 questions or 20 questions. It's quite a bit. Some of it might feel less relevant to you. Some of it's going to feel more relevant. This is what we have to do as part of our entry to the service. Some of it's going to be really helpful. And we might not talk about it all at the time, but it'll really help me to think about how I can support you best and where we're going. So is it okay if we do that right now? Take them with you.
Yeah.
And when they want to tell you more, you say, yeah, I'm just going to have to hold you there. In this bit, we're not going to be able to dig deep in, but that's really helpful. And I'll make time to explore that a bit more, or I can refer you on, because that's really important to me.
Yeah, thanks. I think it's hard to get that discipline when you're in practice talking with people to be able to slow yourself up and not sort of go down each pathway.
But when you think about when you ask questions or it's an intervention, you ask permission for any other intervention. So we ask permission for any intervention, whether it's questions, whether it's interviewing, whether it's what, and we make sure that our agenda is clear and shared. Yeah. We signpost it, but we don't let the patient or the client take over, because we've only got a limited time. You make clear what your role is at that moment and that you've got a limited time.
Right.
These are my boundaries. These are my challenges at the moment.
Cool. Thank you. Oh, I don't know how to mute myself, but thanks very much.
Anyone else in the group want to jump in? Well, I might slip in and ask my question then. Okay, so Rosemary, I'm a researcher as opposed to a clinician, so I am very keen on the measurement side, and I'm trying to remember there's a person on the other side of those numbers. And so my little area of the world is all around activity. So I use Fitbits to collect information. So we're asking our patients to give information about their steps and their minutes spent active and stuff like that. And we're actually not getting a lot of buy-in. So, and I wonder whether is this, because something you mentioned about letting them set the measure, is this something that I need to be thinking about?
I suppose you know, when you're not getting buy-in, you think, what's going on with the process? Why are they not feeling involved? Are they worried about being judged? Are they, what's going on for them? And that's the curiosity. If you think about the behaviour is reporting, do they have the capability? Do they have the opportunity? They've probably got capability and opportunity. So it may be around motivation. If you were to do a COM-B analysis on the behaviour of reporting, and it might be fear of judgment, it could be that it's a bit difficult, it could be how it's built into their habits, it could be anything. So it could be, that there's no reward in it.
Yes, okay, that does raise some interesting, this is just, I want them to get value out of this data, not just me.
Yeah. So the reward in it, and gaming, if you look at gaming's the best at doing rewards. You go into, from one room to another, you'll see lights will light up and hooray,
get a little certificate, maybe a little medal.
Like you get a few more points on your membership, and you get opportunity. So think about how they do reward. We don't do, as health professionals, we're really crap at reward. Oh yes, you're more likely to live longer. That's great. No, people don't want that reward. They want it right now.
Sticker, yeah.
They want to feel good.
Yep.
So we are, if you think about that thinking fast and slow concept, we appeal to that frontal lobe rather than the limbic system. We appeal to the system one, the rational reasoning brain, not to the habit brain. Advertisers are great at appealing to the habit brain. So think of what a happy meal looks like as opposed to a health brochure.
Need to make my activity measurement look more like a happy meal.
Well, we've got to do something.
Yep. All right. So were there any other questions for Rosemary?
There's more. I've got another longer webinar that covers this stuff. I think it's on the Australian Centre for Heart Health website. So if you look that up, you'll probably be able to find it, or I can send a link.
Yes, I will poke that. I'll uncover that and stick it on our.
Because that had more sort of the evidence base and more of the sort of the underneath. I've just distilled everything into 20 minutes without all the thinking stuff in between. But if you take something away, take importance, take confidence, and take theory. Theory to guide exploration and intervention. You don't have to be expert, but to actually be slightly influenced by it would be great, because you will have a theory yourself and there'll be no evidence for your own theory. So it's better to use one that's been tried and tested and sampled and, got thousands and thousands of papers around, rather than one that you've made up because of your family of origin and your beliefs about how people should be, or your own behaviour, which might work for you, but it doesn't necessarily work for everyone else. And the last thing is, if you get frustrated, you're taking too much responsibility and you will lose connection. So frustration is a trigger warning for you to back off.
Yeah, I think that's very practical advice. Thank you very much, Rosemary.
That's okay.
All right, now we'll move on to Linda, because I know she has a client at 2, so we'll give her a chance to get through her presentation. I don't have a big introduction for you, Linda, other than thank you so much for stepping in for the February meeting. I know you're in for March, so April person, whoever you are, you might be dragged forward a month. I'll hand over to Linda. If you want to now share your screen. Yep, that's worked. Thanks, Linda.
That's it. Okay, so while cardiac rehabilitation is part of the Flinders and Upper North Local Health Network, So there's myself here in Whyalla, and then we've got Katrina over in Port Augusta. She's cardiac rehab nurse over there, and I think she was a presentation at the end of the year. I think she did hers. So we're known as a steel city with a population of about 22,000, about 300, 400 k's away from Adelaide, northwest, gateway to the Eyre Peninsula, so located in the Spencer Gulf. And the Aboriginal meaning for Whyalla is place with deep water, which I guess is appropriate being in the Spencer Gulf. Now, how do I get my thing to go? Well, there we go. So, I'll just go back. So I don't know if you can see those pictures.
Yep.
There. Yeah, obviously the steelworks. This is our hospital here. So we've got like the original hospital there, the stack. And then we had a bit of an upgrade, and then this is our more recent redevelopment here, our cancer research regional cancer centre. We got extra like wards out of there as well, and obviously our new jetty, which is a bit different design. So the number of staff that we have, obviously we've got myself, our groups are joined by the pulmonary rehab group as well. So the way we run that is that the pulmonary rehab their education session first, then we meet them in the gym, they go home, and then we have our education session after them. So I guess the reason we did that was due to availability of physiotherapists. They were sort of short-staffed there for a while. So running one combined group was better than running no groups at all, sort of thing. So we've obviously got the physiotherapist with us when we do our exercises, and then with the education sessions, they're provided by different allied health professionals, someone different each week. So you can see there next down there, we've got dietitian, occupational therapist, pharmacist, social worker, and we have a CPR instructor that comes in as well and gives a bit of a session. So we run our course over 8 weeks on a Thursday morning, and mine is like from 10:30 till 12:30. So that's the hour of education, hour of exercise, and then the hour of education. So after that 8 weeks, we offer people like a maintenance exercise group on a Tuesday from 11 till 12. So, you know, the idea of the cardiac rehab program is, you know, supporting clients with chronic conditions, helping them if they've got goals and things that they want to set to make some lifestyle changes, inpatient reviews, one-to-one appointments, phone call follow-ups, which is happening a lot more these days. Home visits, we used to do some of them, but they're sort of dwindled off at the moment as well, obviously due to COVID restrictions, and referring people to other services. So it's not just they come to cardiac rehab. If they need to see specifically a physiotherapist or a dietitian, we will arrange that referral so that they can access different people. As I said, we do the group session. We have one-to-one appointments as well. If people, not everybody's into groups activities, so we have one-to-one appointments, and people can come as often as or as less as they need to, sort of thing. Phone call follow-ups. We also have sort of some hybrid programs as well, which we incorporate the Catch telephone service. I know I've used them several times when maybe our dietitian, like the wait list has been pretty long. So I've offered the Catch dietitian service to clients, and they've accepted that and got a telephone call with the dietitian pretty quickly. And more recently, we've got the chat web-based program as well, which we've been referring people to. And I think especially, you know, some people want to come to the group sessions, but obviously we're not running them at the moment. So they say, oh, we'll just wait till they start up again. But with the chat web-based program, at least they can access different modules and do them in their own time, you know, at their own leisure, sort of thing. And something else we use as well or incorporate is the virtual clinical care home monitoring service as well. So we can offer that to like our heart failure patients, people with hypertension that maybe are changing medication and things like that. So they can have the access to that and monitor from home and be sure that, you know, someone is going to be checking in on their measurements and everything and giving them a phone call if something's not quite right. So our caseload for the year last year was 154 referrals, 58 of them were females and 96 were males. And about 46% actually attended either one-to-one sessions or the group sessions. So that's not too bad. I didn't have enough time to work out the actual completion figures, but I thought 46% wasn't too bad actually attending. And obviously, like, the ages there can vary from 26 to 80. So that top photo there is a new, well, I think it was about 2014 that redevelopment happened at the Regional Cancer Centre. And the bottom one is the old entrance to the old part of the hospital, which we now use as a COVID screening drive-through area. So that was quite handy, that people can just drive up and have their COVID screen done. So this is a gym that we have available here. We have still got all the equipment and everything set out, but like, for instance, these treadmills, we don't use the one in the middle. Well, we're not using any at the moment, obviously, but when it is up and going, trying to keep the, you know, social distancing and that sort of thing. So obviously the middle treadmill doesn't get used. And you can see there how we've had to, like, spread out the chairs and that sort of thing. So, you know, looking at the service, we've sort of adapted service delivery to meet the client's needs, using telehealth to continue providing such service, and incorporating physio reviews more now as well. So I think the physios, you know, are keen for people to do exercises at home, but they want to ensure that people are safe to do that in the first place. So they've started doing a lot more sort of telehealth or health direct, and actually seeing patients on screen or getting them in just to do that one-off appointment and then making sure they were safe to exercise. We incorporate heart failure clients in our cardiac rehab, and I know, like, in Metro they do have designated heart failure nurses, but here we don't have that luxury. So we've got heart failure. We also look at people with arrhythmia issues like atrial fibrillation, and people maybe that have pacemakers, ICDs, and that sort of thing as well. So it's not just, you know, somebody that's had the MI or the cardiac surgery. There's quite a few different little bits and pieces that we do. So some of the things that's the strengths of our program, we feel, is like sort of good communication, excellent communication with local physician and visiting cardiologist. And I know a lot of our local physician, he you know, really appreciates his heart failure patients being involved in the program. And, you know, if they come and see me and there's any issues, I can just contact him straight away and get maybe medications titrated or whatever. And that's fantastic, because, you know, if they had to wait to get an appointment to see him, then that could be a month or so further down the track as well. So it's good having that communication and having him on site. Another thing I thought of, which was really sort of good with our program as well, is the teamwork. So it's not just those directly involved with the group setting and giving the education sessions and everything. As people like a visiting specialist, reception desk, ECG department, you know, people will come and see me as part of their cardiac rehab. And, you know, you'll say, oh, well, when's your cardiologist appointment? Oh, I haven't got one. Or, you know, I have to get an echo done before I see the cardiologist, and they don't have an appointment for that. So just, you know, working with those people and trying to get things running a bit more smoother, and getting things actually done for the client is great. And feedback from the clients. We have had, you know, quite a few people through our group sessions, and we did have one group had a few ladies in it, and they actually still meet. This was about, I don't know, probably about 5 years ago, and they actually still meet for coffee and go and walk along the beach on a Tuesday morning. So, you know, that's really sort of good to hear. One of the ladies that I still keep in contact, like, her mobility is getting less and her condition sort of worsening, but she still goes down and has coffee with these ladies. But yeah, so it's good socially for them as well, and interacting with each other. And yeah, I guess probably most places would say that maybe people do gain a little bit more confidence, happier doing exercises. Once they've been to the gym, they know that they can do them, so they may well continue or maybe go attend a gym outside as well, which is great. So obviously with the COVID lockdowns, and I know that we're not in lockdowns at the moment, but we have got different restrictions to adhere to at the moment. So phone call follow-ups has been a huge thing. Increasing referrals to the physio, like I said, maybe to get that one-off appointment or a Health Direct link up to see them before they actually do their exercises at home. Home visits, we were sort of increasing them a little bit because people didn't want to come into the hospital, but at present we're only really seeing people that really need to. Changes to our service in 2020, 2021. Group numbers were downsized. Things just getting disposable blood pressure cuffs to have for each patient with their name on it. Social distancing in the gym, and making sure that the equipment being used. And that's, sometimes people have got to hop onto something and think, oh, hang on a minute, I haven't cleaned it yet, so just educating the clients that we're using the equipment as well. And yeah, they're pretty good. And we have got one lady that's been coming for quite a long time. She's a pulmonary client, and she'll call us out and say, oh, that machine hasn't been cleaned yet. So, we get onto it. And obviously doing like a COVID screening tool and recording temperatures and that sort of thing. So things that we've had to do more of is like wearing obviously your PPE, more phone calls and physio reviews, referring and offering clients, like I say, the alternative or hybrid programs, which may be the Catch or the chat web-based program and BCC. So I think that's all from me. Thank you.
Fabulous. Thank you, Linda. So just bearing in mind Linda's other commitments, does anyone have a question for Linda? No. Oh, can I ask one thing? How many of your participants go on and do that maintenance program afterwards?
Quite a few of them do. It's probably a little bit hit and miss. So some of them do. And we have, like the group that we had before Christmas, because we were still having groups up until just before Christmas, there was probably about 4. Like we usually try and restrict it to 10. So if there was a big crowd, then we say to some of the old ones that have been coming for a long time, say, look, I'm sorry, but these new people have to come in.
Yeah.
And if it goes quiet again, we'll give you a call. So probably about 4 or 5. Yeah, they'd been there coming for a long time.
Sounds like you've got a great communication with not just your current patients, but all the previous ones.
Yeah.
This is a real upside of the rural health. All right, so we'll draw the session to a close there. Big thank you to Rosemary and Linda for presenting today. And you will be given a little prompt to fill in a questionnaire at the end. Please consider filling it in, don't put questions. I'm taking note of all of our attendees so that we can make sure that we've got good attendance stats to work out who's going to be the brainy ones at the end of the year, who we can go, you guys really understand the chat model. Okay, fantastic. Thank you very much, guys, for this month. We'll see you again in March with a new presenter and a new service of the month.